Good morning. Let's begin the second case here. The patient was a 54-year-old female. She was initially seen in December of 2007 by an outside ophthalmologist due to decreased vision on the right eye that was presumed to be secondary to a peripapillary choroidal neovascular membrane. At that time, her best corrected visual acuity was 20/40 on the right eye. She was 20/20 on the left. And she was treated with 5 Avastin intravitreal injections. And at that time, she was referred to Kauai for further evaluation and management. Before the transfer, the outside retina specialist, he ordered a series of blood work and some tests.
I probably would not have ordered any of this.
Okay.
Go ahead.
So when she came here, we first saw her in the beginning of November. What she described is, this is the way that she described it, was like a smoke screen over my right eye. She had no pain, no flashes. Is before she presented here to Cole. This is from March of 2008, before the Avastin therapy, when she started seeing the outside retina specialist. Does anyone want to describe what you see here?
The retina overall, I note some kind of sheen superior to the disc. Perhaps that's the subretinal fluid that they were seeing.
But the lesion itself, we didn't see any intrinsic vessels throughout the entire study.
So I think given the patient age and female age, I think 57 or something like that, and then the appearance of lesion, and I would certainly include the lymphoma in the differential, and also melanoma, and possible metastatic disease because she had a...
Well, I think the metastatic melanoma would be on the list. And also, it being sort of a creamy lesion like that, you can't only discount the possibility of a granuloma. So I would probably throw sarcoid in there. So maybe I would have gotten the chest X-ray in the study.
Mm-hmm. Okay. Well, given her presentation in the pattern of the B scan and the ICG, what we thought initially that was she was clinically suspected to have a choroidal metastasis from an unknown source. So before coming to Kauai, the outside ophthalmologist had also ordered MRI of the brain and orbits, which was
on the FA throughout the study, right?
yeah.
Yeah, and most granulomas will eventually, they'll stain or they'll leave.
So in the meantime, we got the results of the CT scan of the chest, abdomen, and pelvis. On the chest, it showed only some non-specific nodules that were less than 4 millimeters. They just recommended a follow-up scan, but there was no evidence of malignancy. Abdomen CT scan was unremarkable, and the pelvis CT scan showed some questionable endometrial thickening, but no evidence of malignancy. Thought that this was a case of choroidal metastasis. Basically because they are typically yellow in color, associated with the subretinal fluid. And just to discuss a little bit, up to 34% of the patients have no known history of cancer at the time of diagnosis. Given the absence of the intrinsic vessels and the development of the large gliotic plaque.
Well, this is the gliotic plaques and treated melanoma following transcript chemotherapy. Pretty much identical appearance. I've only 3 cases of Avastin because failed melanomas, fortunately only 3. And I only saw this in 1 case. The other cases don't see that kind of membrane. So,
Were they getting Avastin treatment?
no, they were giving Avastin before.
An adequate attempt? Did they get monthly injections for,
Yeah, 6 injections.
a long period of time? And then the ones that you found are going to be the ones that didn't work. Maybe there are hundreds out there that all went away and you never see. So, I don't think it works, but to find a couple cases where it doesn't work, it's hard to argue that it doesn't work.
It might work for new melanoma that they mistook for
corrosion neovascular.
One important clinical feature, and there will be others too, is that if the disc is involved, then that's not juxtapubic membrane, because juxtapubic membranes are stop at the disc margin, the disc is not swollen by itself.
Okay.
And even in the first photograph, which is poor quality, somebody mentioned there was disc edema. So that goes against, in my view, the diagnosis of juxtapubic membrane. Why would the disc be swollen in that form unless there is something infiltrated?
Well,
So if you find disc swelling associated with membrane, I think you should always think about
I had one case that he took out a peripapillary choroidovascular membrane with pseudotumor. Now that's a problem because it already has disc edema. So I think you can get fooled, because it could be the other way around. The disc edema could cause a crack at Brooks that produces the choroidovascular change, but in that case it's bilateral disc edema.
Posterior scleritis, I mean,
Yeah, that was the report that we got. We don't have the scans. And that was the reason. On the letter of referral, he mentioned a questionable posterior scleritis and that he ordered that blood work that I showed. And everything came back as negative.
I just wonder what the B scan looked like. Thinking back, it seems like there probably was some sort of mass discernible, I guess, even at that time, or maybe some thickening that didn't look like scleritis. I don't know.
Well, ultrasound, as you know, is operator dependent, so it depends who's doing it and who's looking at it. So that has a large variability from there. Especially for smaller lesions, it's difficult to do much of interpretation.
Wasn't that pigment blocking on the fluorescein, the original fluorescein, that
Yeah.
would make you wonder why that would be called a CNVM?
But there are, he said, there's some leakage too down the line, so we thought there was a membrane that was leaking.
I mean, Arun, if you saw this or if someone else saw it, would that blocking be concerning or no?
Well, there has to be hemorrhage or pigment or blockage, and